All right. Well, I am so pleased tonight to introduce our presenter, Dr. Ruby Kalra. She is a pediatric hematology oncology specialist and has over 34 years of experience in the medical field. She graduated from University of Illinois at Chicago College of Medicine in 1988. She also completed a fellowship recently in integrative medicine and just sat for her boards in May, she was sharing, and is also a certified yoga instructor. So what hasn't Dr. Kalra done? She's so knowledgeable. Was looking it up on our database, and she presented this program in 2018, and it was so well received. We really wanted to have Dr. Kalra back again. So we are so pleased to have her tonight, and I will hand it over to you.
Great. Well, thank you. So as you may know already, the purpose of tonight is to really talk about tests. And I know that there are so many tests involved in a cancer diagnosis, and oftentimes there really isn't a lot of time to prepare for these tests, nor to really understand many of these tests that repeat over and over throughout the therapy. So go ahead and delve in. Let me get my slides to advance. Oh, great. We're all set, and now they're not advancing.
Are you doing the arrow buttons or?
I am.
Huh.
It worked before.
It did. We gave
and
it
it just stopped. We really literally tried it.
If you progress on the actual PowerPoint, does that work? And if not, then we could try stopping the screen share and then resharing again.
Oh, wait,
there we go.
Maybe it's just only working with my mouse. That's fine. Okay. So basically, I just wanted to start out by introducing myself further. My name is Ruby Kalra. I am a pediatric hematology oncology doctor. So there might be some things that I may not necessarily get in some of your Q&A later. And I just wanted to let you know that in advance. And as Rachel said, I did recently board in integrative medicine, which is a great interest of mine. And I'd like to thank Rachel for inviting me back. And we were just saying how long it's been since with the whole pandemic and all. It was last year, pre-pandemic. And I want to thank you all for being here. I know that life is busy, especially with the cancer diagnosis, but I do truly believe in the power of knowledge and understanding and good communication. So I really encourage you to always make sure that you feel that all your questions are answered and that your medical team is really there with you answering those questions. So whatever your story may be with your cancer diagnosis, one thing is for sure, and we know this by research, that once people are being told that they have cancer, they typically hear nothing more of that initial conference. And these conferences can go on for quite some time with lots of information about what next and what the treatment is and what have you. And most patients are still going, wait, what? Cancer? And so I always tell people, please ask your questions over and over. And there's no such thing as a dumb question. And be sure to write down those questions that pop up, especially later at home or in the middle of the night. You think, oh, I'm not sure what happened here or what they said here. So I'm kind of going to go through this as sort of a timeline. Like, you know, when I first see a patient, usually they come to me because either they have an abnormal lab test, or they've had an abnormal x-ray, or perhaps they've had a symptom, have gone to another doctor or to the emergency room with complaints such as pain, or maybe blood in the stool or something like that. And then as the oncologist, it's really my role to figure out what exactly that we're dealing with. A lot of times people have a lot of confusion between a solid tumor versus a blood disease. So when I say blood disease, I'm generally referring to things like leukemias. And, you know, patients will say, well, I have leukemia, but I'm not sure if it's metastatic or if it's spread or not. But, you know, with blood diseases, we don't really talk in that term because it is the blood, and the blood traverses throughout the whole body. So it's not really metastatic. It is just the leukemia, which does involve the whole body. Whereas if for a solid tumor, such as a lump, say, in the arm or the breast, it can be local, meaning where you feel that first mass, and then it can also be metastatic or spread to other organs. The best way to know what a cancer is, whether it be one of the blood or one of a solid type tumor, is to, of course, get a piece of tissue, and we're going to talk about that later. Some cancers also have what things are called tumor markers, which we'll talk about, which can be things that are in the blood that give you an indication of something abnormal that the cancer may be producing. And you're going to end up seeing a lot of different specialists is part of your care team. So the oncologist is the doctor who takes care of the cancer. The radiologist is the person who's actually reading all the different films that we'll kind of talk about. The surgeon, of course, would be involved in a biopsy. And the pathologist would then take that biopsy or the tissue from the tumor or the blood sample of a leukemia patient and then run tests in the laboratory to ascertain what type of cancer or leukemia is it. And then in addition to your oncologist, you may also see a radiation oncologist if your particular type of cancer is also sensitive to radiation therapy, and that's part of the plan. It may or may not be part of the plan for all cancers. So what is cancer? And this is where people really get confused because they tend to think of cancer as one disease. And unfortunately, it's not one disease. It's really a collection of diseases where a cell, usually an immature cell somewhere in the body, whether it be the bone marrow, which is the factory for the blood, or any other place in the body, such as muscle tissue or bone tissue, that starts to replicate itself in its immature form, doesn't really have any function other than to continue to make more of itself, crowd out healthy cells, and it can cause the symptoms based on where it's located, such as pain. And then it can, of course, travel to distant sites or metastasize, which is what we kind of talked about earlier. When I see my pediatric cancer patients, one of the first things I often talk to families about is that there is no blame. Cancer, we typically don't find out why these things happen. They're usually a whole compilation of factors involved, such as genetics, both in the tumor and the types of genetics that are inherited through parents, environmental factors, dietary factors, physical activity or sedentary levels, stress levels, smoking, certain viruses we know have been implicated in certain cancers. All of these things can work together to cause a cancer, but it's really best not to dwell on why, because there is no good answer. And the time and energy spent on blaming or wondering is often not really productive. And because cancer is not one disease, it's also, unfortunately, not just one cure or one type of cure. So the initial test, as I said, if someone usually comes to me with, say, symptom of something, pain in the leg or something, the first thing we'll do is imaging. And imaging is basically x-rays, different types of x-rays to look to see what's wrong wherever the symptom is, and then later also to see other sites of the body where a tumor is traditionally known to possibly spread to. Some types of tumors like to spread to the lungs, some like to spread to bone marrow, some like to spread to bones, some have a combination of these kinds of things. And so image x-rays are really important to follow up on that. The second thing that we do once we've got the imaging, we know where everything is, and the surgeon can look at the extent of the tumor and decide, am I going to take it all out? Or am I just going to biopsy it or take a piece of it to find out what is it? And here at this point, I want to just throw in, I put in parentheses here, the role of second opinions. Often this is a place where we find patients asking, once the tumor's been biopsied or taken out fully, and the pathologist has looked at it and said, this is the type of tumor, patients often ask, are you sure? Are you sure this is the type of tumor we're dealing with before I start on any treatment? Is this what I have? And that's a valid question. And this might be a time when you can say, was the sample sent out to another institution or another place that's best for evaluating this type of tumor, or how confident are you that this is what I have? And then we mentioned tumor markers, which I'll get into a little bit later, that can help with that diagnosis piece as well. The next set of labs or tests that I have down here are things that we'll do in the beginning. So the complete blood count, the liver function, kidney function, heart function, pulmonary or lung function, to assess to make sure your body is well and able to handle chemotherapy, or if there needs to be any adjustments. And then these are also tests that you'll become very familiar with because they're repeated throughout the therapy to make sure you're tolerating the therapy. So we'll start with imaging, and here's just a picture of a CT scan. It's showing a cross-section through the torso of the body, and you can see that things are labeled here. So under the right rib cage is typically the liver, and part of that is the gallbladder, and over on the left is the spleen. And you can see in the middle and the back is the vertebrae or the spine, and then there's some ribs kind of going all around the circumference of this CT scan. So just kind of an idea of the image that we see on a CT scan. So a CT scan or a CAT scan, sometimes it's called, or computerized axial tomography, though I have to say in medicine, we rarely say anything the long way. We always use short abbreviations, which can be confusing because so many things have multiple names: CAT scan, CT scan. What is it? It's all the same. And this is a type of scan that we've had for very many years, mainstay of looking at different types of solid tumors. And it does have some radiation exposure because it does use traditional type of x-rays along with a computer to really give you that cross-section and detailed view of the body. Often it's given with IV or oral contrast, which means that you either drink something or something, dye is injected into a vein, and that's to highlight the tissue better, especially the cancer tissue. Patients sometimes will say that dye contrast might leave a metallic taste in their mouth. It also can affect your kidney function. So if you already have poor kidney function, that's something that it can be tricky to give contrast dye with. But generally, this type of scan is really quite well tolerated. And here's just an image of what one looks like. I'm sure many of you have had many a CT already, but you can see the patient lies on a moving little gurney that goes in and out of this scanner. And it's not as claustrophobic as the next one that we're going to talk about, and that's the MRI, or the magnetic resonance imaging. This one is really replacing CT for many things because it really can give us better detail. It also, for us in pediatrics, it's replacing CT scans in many ways because we're not risking exposing a young body to radiation like we do with the CT scan, since this is magnetic and no radiation. This is, however, a smaller space, and it tends to be harder for people who have a sense of claustrophobia or get some anxiety from being in something like that. So a lot of people will say tips for getting through having an MRI, in addition to asking for anti-anxiety medications, but earplugs or aromatherapy. You can get these essential oil aromatherapy stickers like lavender that you can attach to your clothes, and they're not magnetic. They can go through the MRI scanner. In fact, that's what they were made for. And mindful breathing, all those kinds of things can help you as you're getting your MRI. And this also uses a contrast called IV gadolinium, which is injected into the vein. And here's an idea, a little diagram of the MRI. You can see it. The top one is a typical MRI, which is considered a closed MRI. So it's a very, very small space. Rare to find open MRIs. And in fact, the closed MRIs actually give better imaging, but there you have it. And then really over the last decade or so, PET scans have really become an important part of our imaging, and PET CT together have really been very important, especially for things like lymphomas. And what this is there's an injection of a small amount of radioactive substance, the FDG, or the fluorodeoxyglucose, which is basically sugar. Cancer cells love sugar, so of course they're going to take this up much more so than the regular cells around them. So this highlights where the cancer cells are. And in Hodgkin's lymphoma, we can use this to say the degree of PET activity from the first scan. After 2 cycles, we'll repeat it and look to see, is that PET uptake, is it less? And that gives us a better idea of how the tumor is responding to the therapy. And then ultrasounds have been around for a very long time. Same technology as, say, a woman who's going in for ultrasounds as part of a pregnancy. There's just a machine that passes high frequency sound waves through a transducer, which is just a wand that's placed over the area that's being imaged with a little bit of some ultrasound jelly to help with the transducer move and to get a better image. No radiation, quick and easy, oftentimes might be the first starting point where you can get an idea of, is this a cyst, is it something solid, what's here, and then go for something more specific like an MRI or a CT for more detail. And then just a little slide about breast cancer screening. Another way that people obviously come in with a diagnosis is that, they may have done a breast self-exam and found something themselves, or maybe getting a routine mammogram or MRI or ultrasound as part of their screening. And similarly with colorectal cancer screening, I put this in because colonoscopies are recommended every 10 years, 5 years for some if you've had an abnormal colonoscopy with some polyps. And we've lowered the age because younger and younger people are being diagnosed with colon cancer. So we kind of talked about all the different imaging, including the colonoscopies, endoscopies, like that. And then once we know where the tumor is, then the surgeon is involved in getting a piece of the tumor or taking it completely out. If you're getting a piece, that's called a biopsy. And that tissue is very vital to make the correct diagnosis. What are you dealing with? We can have an idea, depending on where the tumor is located in the body, what the likely diagnosis is, but unless you get a piece of the actual tissue through the biopsy and look at it under the microscope and do all the different tests that the pathologist does, you really cannot fully identify what the tumor is. Many ways to do biopsies. A surgeon can do an open biopsy, meaning that there's a large cut or opening to the body or large incision. You can do them laparoscopically, which is through these fiber optic camera instruments that go through the belly button. Endoscopic, meaning like a colonoscopy, and then getting biopsies that way. Sometimes we send you to radiology and they actually are imaging you at the same time that they're putting a needle through the space and getting a needle guided biopsy. And then bone marrow aspirates and biopsies, which are generally done for looking for either spread of a solid tumor to the bone marrow space, or for, as I mentioned earlier, the bone marrow being the site of where leukemia starts or a blood cancer. So then once you have the tissue, it goes to the pathologist, and the pathologist looks at the tumor under the microscope. They can tell us some quick, easy things right away, whether there looks to be a high mitotic rate, which means are the cells dividing a lot? Can you see the chromosomes actually splitting in that sample? And if they're seeing a lot of that, that gives you an indication that this tumor is rapidly growing. And they can look and see how the cells look under the microscope. Do they look very similar to what they would have started at as what they were going to be? Because remember, I said they're immature cells. So are they pretty well differentiated? Do they look pretty much like what they were going to be, or do they not look at all like what they're going to be, and often very bizarre? Those tend to be more of a higher grade. The pathologist is also looking if the surgeon has taken out the tumor in its whole entirety, whether there's margins involved, if there's anything left behind in the body, or if that when you took out the sample, all the margins around the sample are normal, healthy tissue, and then you can sort of see where the cancer ended and now removed. Also assessing lymph nodes if the surgeon takes out some regional lymph nodes around the site of where the tumor was. If it was, say, a breast breast tumor, then looking under the arm where the breast would drain to see if any lymph nodes would be involved in there. And things have gotten really, really high tech with pathology now, identifying specific genes and proteins associated with tumors, which again help us to identify what type of tumor it is. So as time goes on and people go back and look at old tumors, sometimes they find, oh, with these newer things, tumors can be classified. And I just put in for staging here that a lot of the staging systems include the tumor size, whether nodes are involved, and whether there's any metastatic or spread disease, and the pathologist can help with all that. Then I mentioned tumor markers, which are substances produced by cancer cells, and they go up in the blood usually, and they can be serially followed over time to see if the tumor is responding to therapy or if the tumor potentially is coming back after the completion of therapy. No, unfortunately, universal marker that you can use for all cancers, but certain ones will help with certain cancers. And I've put in a couple here that people may have heard of, such as the prostate-specific antigen for prostate cancer. For us in pediatrics, we tend to do a lot of the alpha-fetoprotein or AFP and the beta HCG, which is also the same as the pregnancy hormone, but different here in the setting of tumor for a type of tumor called germ cell tumors. But different things that the pathologist can look for, or your oncologist can look for in either the blood or the tissue. And here's a couple, a whole list of other things that you may have heard of, such as the BRCA1 and BRCA2 genes, which can be mutated in breast and ovarian cancer. There's BCR-ABL was one of the first mutations that we first associated with cancer, especially leukemias. And I bring this up, I brought this slide in when I gave this talk in 2018, and back then a lot of the clinical trials for pediatrics or children in our country are run through the Children's Oncology Group. And a number of years ago, the Children's Oncology Group set out to see if they could screen 1,000 patients and look for genetic changes in that tumor and look to see if any of them would be what we call actionable, meaning that if we know how that genetic change gave that cancer cell a growth advantage, and then we found a drug that counteracted that signal, could we then be taking action against that genetic change? So 1,000 patients were screened, and they proposed at the start of the study that they would likely find about 10% of those tumors might have an actionable change. And the study concluded and actually found 31.5% of those first 1,000 tumors screened actually had an actionable target, which meant that they had a medication that they could use other than chemotherapy that was specific to what was driving the growth of that cancer. So pretty impressive. And similarly in breast cancer, this TAILOR-X trial looked to see if looking at 21 different genes associated with breast cancer, if they could potentially change the amount of therapy that women needed. And they did find that they could decrease the amount of therapy for a specific subset of women. And so we call these things risk factors. And if the more and more risk factors we find out, the more and more we can do what's called precision or personalized medicine, and really just say, well, you may need more or you may need less therapy, because our goal, of course, is to have the best survival, but with the least amount of side effects. And this is a really busy slide, but it's just to show you all the different pathways that potentially could have a actionable drug that's currently available to target. And so the timeline for the tests, we talked about the fact that at the diagnosis, we're getting the x-rays, we're getting the labs and the your function tests to make sure that you are ready to handle chemotherapy. And then prior to each cycle of chemotherapy, we repeat the tests again, and we're looking at to see if your bone marrow is ready to handle more chemotherapy, if your liver, your kidney, your heart, your lungs. Typically, chemotherapy, the type that makes your blood counts go down, is given about every 3-week cycles. You might have other drugs in between, like on a weekly or every, you might have 3 drugs on day 1, and then 1 drug on day 7, and another drug on that same drug on day 15. And then at the 21, 22 day, you're ready to start all 3 again. And that's because it takes time, about 7 to 10 days for your blood counts to drop after chemotherapy, and then another 7 to 10 days for them to come up. So that's why these tests are so frequent, and they're going to be repeating. And they'll continue even off therapy to make sure, as I said, that the cancer remains in remission, and then also there aren't any late effects of the treatment. So let's get a little bit specific about some of these tests. The CBC, or the complete blood count, is one that you will be very familiar with. And this one I print out and show to all my patients every time they come in, and they're very familiar with looking for what the different parameters are that we are looking at as their oncologists. And that includes your white blood cell count, because this is what helps you to fight infection. Your red blood cells are what give you energy. They carry your oxygen around. And typically we look at the hemoglobin when we're looking at these to see if you're anemic or not, if you need a blood transfusion. We also look at your platelets to see if you need any platelet transfusions. Platelets help you to stop bleeding. When your platelets get low, you end up having bruising or bleeding. So as I said, usually you'll check your blood count, your CBC, then you'll give your chemotherapy if your counts are good enough, and then your counts will be at their low point 7 to 10 days after what we call myelosuppressive chemotherapy, meaning chemotherapy that's meant to drop your counts, and then a week or so to recover. Sometimes we give growth factors for your white blood cells, such as GCSF, Neulasta, things like that, that help you to have a shorter amount of time when your white cells are low and you're prone to infection. So here's just a picture of what your blood looks like under the microscope. The majority of the cells that you're seeing there that look like little donuts are the red blood cells. The large cells with the purple lobes in them, those are your white cells. And then there's little small specks that are purple and solid, and those are your platelets. And this is a typical printout that you might get for your CBC, showing you your white cell count. It'll show you your result. It might flag things as low or high with an L or an H. It'll show you the units, which you don't have to pay attention to. And then it'll show you the reference range as to what's normal. and what's not. So you'll see the white cell count, the hemoglobin, the platelets, and then it'll show you a whole list of different types of white cells. And here I'm just going to talk about white cells. The normal adult white cell count is between 4.5 and 11. I'm not even going to go through all those units. You can just remember or look at the ranges that are on your printout. And white cell counts can go high with the result of leukemia or lymphoma or infections, or sometimes with certain medications like steroids. And a low white count, of course, can be from chemotherapy, and sometimes overwhelming infections can also make you go high or low. And we often focus on the ANC, or the absolute neutrophil count, which is, I had mentioned, there's all those different types of white cells. The ones that we focus on for your ability to fight infections, serious bacterial infections, are your neutrophils, which are also called your segmented neutrophils. So a lot of different names, or your polymorphonuclear lymphocytes. Again, all the same thing. Your neutrophils will calculate your absolute neutrophil count, or your ANC, which is what percentage of your total white cells are these neutrophils, and then the absolute means you multiply it all out. So here I gave you an example of your white count was 5,000 and 50% were neutrophils, then 50% of 5,000 is 2,500, and there's your ANC, or your absolute neutrophil count. And a normal absolute neutrophil count is usually above 1,500. When we worry about infection risk is when it's less than 500. And so we'll say, you're neutropenic. If your ANC is very low, we'll ask you to really be careful to avoid infections. We've all learned from the COVID pandemic, washing hands is very critical, especially before eating or drinking, and not sharing utensils and food, avoiding all contacts, masking, especially in crowded places. And, some people talk about a neutropenic diet. The main thing I say is just avoid things that are unpasteurized or rare, like sushi, or rare carpaccio or something like that, something very rare, because you would be more likely to be sickened from something like that, the weakened immune system. And then we mentioned hemoglobin, which of course is that protein in the red cells that carries the oxygen, gives you the energy. Normally, men are around 14 to 18, and women are more 12 to 16. Women tend to be lower because we menstruate. And we also don't have the same hormones that drives all that hemoglobin production. So signs of anemia are that you're fatigued, you're pale, you're possibly short of breath with exertion, especially. You might feel lightheaded, especially from going from a seated or lying down position to standing up suddenly. You might feel dizzy. So typically we'll do a blood transfusion if you're around 7 or 8. And a way to support your hemoglobin or your blood production is eating iron-rich foods and foods with B vitamins, especially B12, B6, folic acid. And then platelets, as I mentioned earlier, are what help you to stop bleeding. And so normal is about 150 to 450,000, and we'll transfuse when you get down to 20,000, 10,000 usually, or bleeding. And here's just a picture showing you what petechiae look like, which is tiny little bleeding in the little capillaries right under the skin, or in that case, you can see at the back of the throat. So that's the CBC. And then the liver functions, these are also blood tests, and we generally check these pretty much with every, prior to giving every chemotherapy. We'll look at liver enzymes such as the AST or the ALT, and these generally tend to get elevated with chemotherapy. We typically will accept levels as high as 10 times normal before we'll actually make a change in the chemotherapy and hold it or wait. And we'll also check your bilirubin level, which is another one of the liver function tests. And the bilirubin is that yellowish pigment that makes babies jaundiced when they're newborns, when they get a little yellow and they go under the bilirubin lights. Same thing here. When your bilirubin levels get very high, that's another thing where the chemotherapy might get held for. So maintaining a healthy liver, it's really important to avoid alcohol, because alcohol is damaging to your liver, especially when you're getting a lot of different medications. Because remember, drugs have to be processed in one of two places, your liver or your kidney. For the most part, it's the liver. And if you're taking an excessive amount of pain medications, such as Tylenol, that can also impact your liver. Certain medications, such as seizure medications, Some TB drugs can affect your liver, and certain supplements can affect your liver. So it's always really important to talk to your oncologist about all the different medications, as well as the different herbs and supplements that you may be using. Some of these supplements, I should also mention, can increase or decrease the drug levels of certain chemotherapy medications, or other types of medications that we sometimes use with cancer therapy, including things like blood thinners. So really important to talk about supplements and herbs. Kidneys, again, your kidneys will get rid of a lot of your chemotherapy byproducts through your urine when you pee it out. So it's important to maintain good kidney function. Many of these drugs also affect your kidney function. So the test that we check for your kidney function is your serum creatinine. And I put the range in there. Usually, if you remember, around 1 is normal. That's pretty much what you need. Sometimes there's fancier tests, such as the glomerular filtration rate, which is looking to see how fast your kidneys are processing things and getting them out of your body. Those can be done through things like, sometimes you'll have to do a 12-hour urine collection at home and bring the refrigerated urine collection into the clinic, and they'll send that down to the lab to see how well your kidneys are filtering your waste. Also, different electrolytes or salts are part of your kidney function, as is your blood pressure. Your kidneys help maintain your water and salt balance and your blood pressure. So those are all things that we look at to assess whether your kidneys are handling your chemotherapy. And here's just a list of some drugs that are also can affect your kidney function, and radiation, of course. And sometimes we do end up giving radiation to the kidneys. So maintaining a healthy kidney, it's important to stay very well hydrated. I recommend at least 1 or 2 of the 32-ounce water bottles per day. And again, avoiding alcohol, and talking to your pharmacist and your oncologist about other drugs that can affect the kidneys, certain antibiotics, which a lot of the cancer patients end up taking when they're sick. It's important that things don't get too additive and pile on and affect your kidney function. And sometimes we end up having to take out 1 of your 2 kidneys if your kidney's involved in cancer, and that's part of the treatment. But it's important then to be vigilant about your remaining healthy kidney, and really avoiding medications that are toxic to the kidney, and avoiding contact sports, which might destroy that other kidney. Heart function, certain drugs do affect the heart. And so oftentimes we will do what's called an echocardiogram, which is basically an ultrasound of the heart, looking at how forcefully the heart beats, and as well as looking at the structure of the heart and all the valves, and making sure that everything is flowing well. EKGs are part of that, with leads looking at the heart rhythm, blood pressure, your heart rate or your pulse. These are all things that we'll look at. Chemotherapy and radiation both can affect the heart. And then pulmonary function tests, certain medications specifically can affect the lungs. And so we may send you to get a pulmonary function test, where you're blowing into a machine that will do a whole host of calculations for how well your lungs are working. And exercise is really important for healthy heart and lungs throughout your treatment. And it's also really important for mood. A lot of times people don't feel that they have the energy to exercise when they're undergoing treatment, but I think it's really important to just get up and move as much as you can, even just, small bursts of 5 to 10 minutes of walking, a little activity throughout the day is really helpful. We may also check fertility and hormonal levels, because a lot of our chemotherapy may affect your fertility and your hormone levels. It's possible that you might go into early menopause or other things like that. So it's important to talk to your physician before starting treatment about your options for preserving fertility, whether it be sperm banking or freezing eggs, or taking a piece of ovarian tissue and preserving that. All very important. And then as follow-up labs for during and post chemotherapy, will continue to check your thyroid function and various other hormone levels, to make sure that your endocrine system, your hormones, are functioning and are being produced at the right amounts. Radiation, of course, can affect this as well. And remember, your hormones can be produced in multiple places in your body, including your brain. And this is no real test to assess this, but no talk about cancer would be really complete unless we said, how are you doing emotionally? And sometimes that's just having your caregiver or your team just sitting down and saying, how are things? And Are you getting support? And sometimes it's really just unfortunately up to you to reach out and ask for that support from friends and family, and to ask your medical team, that you need additional support. Medical teams often consist of social workers or a chaplain or a support group like here tonight. So it's really important to know that these services are available. And it is unfortunate that sometimes it really does, unfortunately, need the patient to be the one to say, hey, I need some help. Where can I go to find this? So here's a little tip about, when you're finishing therapy, what we often give our patients are treatment summaries and survivorship plans, talking about, the type of chemotherapy they had, the dosing that they had, the kinds of late effects that we might expect to see, and how often they need to have certain tests. Typically for a leukemia, we'll see a patient in that first year every, 4 to 6 weeks. And then in that second year, every 2 months, and less and less, 3 months, 4 months, 6 months, all the way out to 5 years. For a solid tumor, usually we'll do imaging every 3 months for that first year, maybe every 4 months for the second year, every 6 months for the third year, kind of less and less. We typically don't say that you're a cancer survivor, that you've cured, until you have hit 5 years from the end of therapy. And that's typically the definition. Certainly everyone is a cancer survivor, but the cure is where we get to is at 5 years. Here are some reputable online resources. I know there's a lot of resources out there. Sometimes it can be very confusing and they can be contradictory, but I really do trust these resources. I think they're really great. So I've put them here, and I'm glad that you'll have access to these slides for later. And now that is the end of my presentation. I'm really here to answer any questions, and I hope that you will use this to really make sure that your medical team answers your questions specifically, because it's very important that you feel heard and that you feel that you understand your treatment. It's also really important to keep records. I always recommend to my families to keep a record of the surgical report, the pathology reports, any imaging results that they might have. You don't have to keep every, daily or weekly CBC, complete blood count, or anything like that, but you want to keep the big things in a binder. Some patients keep all of every single report, but it is really important to have that available. And especially as you move off therapy, it's important to come back and look at that. And sometimes people don't expect it, but they move and they have a new provider. Certainly you can request medical records, but it's nice to be able to have a compilation of your cancer journey. So with that, I will end.